Boa tarde. Good afternoon. Thank you all for joining us in the session 12 on this last day of our conference from the 13th conference of the International Network for the History of Hospitals. A session is titled The Politics of Modernization, and we'll have 3 papers. First one will be presented by Barry Doyle and has the title The Shape of Things to Come, The Politics of Planning New Hospitals in Interwar Europe. Barry Doyle is Professor of Health History and Director of the Center for Health Histories at the University of Huddersfield. He is specialized in the history of hospitals in the modern period, offering comparative analysis of provision in a number of countries, including England, France, Poland, Hungary, and Czechoslovakia. His research has been funded by Wellcome and ARTIS, and his publications included a 2014 monograph, The Politics of Hospital Provision in the Early 20th Century Britain, and numerous articles and book chapters in English and French. He is currently editing a special issue of European Review of History with Hannah Louise Clark on imperial and post-imperial healthcare before welfare state. He has been a member of the board of the International Network for the History of Hospitals since 2013. Barry, 20 minutes, please.
Okay, thank you. Hopefully you'll see can you see my PowerPoint now?
Yes.
Okay, I shall stick it up to that so you don't get scared by seeing how many slides there are, which means I'm going to have to go at considerable speed. So this paper, as its title says, and thank you very much for the introduction and the invite to talk. It's looking at the ways in which hospitals in England and France were funded and designed, and the controversies that both of these caused in the interwar period. So thinking about the way in which the English have looked at hospitals, there's been a lot of work recently about hospitals in England, and the historiography of that interest in hospitals is focused mostly on income, but not very much on capital expenditure or extensions. There's been a lot of research around financing hospitals, but far less about hospitals themselves as buildings. The key piece that's been written until relatively recently was Jonathan Hughes, who wrote an article about post-war hospital building and its architectural approach. Some regional studies, Jonathan Reinhardt, John Pickstone, myself, have picked up on kind of the building of particular hospitals, whilst John Moen and Martin Power have looked a little bit at local authority building. But in general, the kind of discussions about building hospitals between the wars are relatively few and far between. In France, the situation, I would say, is much the same, if not worse. There's a bit of a tendency to focus on the stars of French interwar hospital buildings. So the first is the big Grange Blanche development in Lyon, which came at the beginning of the 20th century. And those of you who know anything about hospitals can tell it's a pavilion style. It's many separate small buildings, and kind of represents the old-fashioned way, maybe, of designing hospitals, the late 19th century version. And then Hôpital Beaujon in Paris, North Paris, built in the early 30s. This is very much a modernist version, but still kind of within European context rather than the kind of things that begin to happen in America by this point. So Jonathan Hughes did say that architectural design is not a neutral, value-free resource from which architects draw as they desire. The layout, design and styling of buildings can manifest the geographically and temporally localized thinking, aspiration, prejudices of their designers and clients. And by that, he's meaning that hospitals are not just sort of drawn from a pattern book, but in fact, they are shaped very much by their locality, by what is possible, by local prejudice, and often, very often, by the amount of money available to complete the task. What? What's happening? Right. Okay. So what I'm going to do is give you two case studies, one from England and one from France, of new builds or attempted new builds. I think it's probably a bit more accurate to say, of the interwar period, one of which has actually received quite a lot of attention recently in a great book about hospital building, which came out a couple of years ago. It is very much a sort of modernist architectural historians kind of dream in many respects, although that's in fact what it turned out to be. It was never built. And the other one, not built for different reasons, a more prosaic design. So I'm going to look at how they were financed and also the politics of designing a hospital building. So you can kind of look at this. It's just a little bit of background, the fact that hospital systems are not financed, A, like they are today, or B, in the same way between different countries. And in England in the interwar period, there are in fact two different ways in which hospitals could be financed. They could be financed by the municipal, by the local authority sector, and those focused on funding and building and providing care for the chronically ill, the very, very poor, people with infectious diseases, those types of patients, but not the general sick. The sick and acutely ill were looked after by what were called voluntary hospitals, funded by donors, by subscribers, and by contributors. National insurance, a very extensive national insurance system exists in Britain, but it doesn't cover hospital care. And the central government keeps out of the funding of voluntary hospitals, although it provides loans for the municipal hospitals. In France, there's kind of, all those things all exist, but they're all embodied in one single way of building and delivering hospital services. There's still an extensive donations, legacies, and endowment system, which funds a lot of cities like Lille with an old hospital tradition, but newer cities like Le Havre, they rely much more on tax revenue, on local state support. And from the end of the 19th century, as in Britain, you start to see state insurance coming into play, but that only covers the very poorest through what are called AMG and AO. The elderly are covered by those. But that starts to bring in kind of assured income into the hospital system. And then in the late 20s, early 30s, a system like national insurance is instituted, covering up to 40% of the population by the start of the Second World War. And that does cover hospitals, and that injects a lot of money actually into the hospital system. And the central state is also willing to provide loans for the cost of building projects. So this is just like a quick bit of illustration, types of hospitals being built in England between the wars. This one here is an ideal typical hospital design. It's how a hospital should look. And interesting that there's a building done in Leeds, an extension, which actually looks very like this. There's this big municipal hospital, local authority hospital built south of London, in South London at the beginning, just at the end of the 1930s. This is a tuberculosis hospital in South Wales. And this is very much a kind of modernist pattern for tuberculosis hospitals. It's got curved south-facing wards with sunlight and fresh air seen as important elements of that treatment. And one of the few big hospitals for general patients built between the wars is the Royal Masonic Hospital, which is actually private. So you can see from this, actually, one of the things that you see is very few new voluntary hospitals between the wars. And that's because they're expensive. So here we see a building scheme in Sheffield. Sheffield has a thing called the Sheffield Hospital Council, which is an organisation that provides, brings together the different hospitals in the city, raises money for them and helps them to spend that money, decides on strategy for spending money. And so the Hospital Council acquires a site for a hospital. It's going to be on the edge of town. They abandon that. And instead they decide in the mid-1930s there's going to be a super hospital in town next to the university. And here we have a little kind of illustration. So all these little hospitals already exist and they're going to build a new one down here, bringing together all of the different types of hospitals on a single site. And there'll be a new maternity provision and there'll be a new radium hospital as well. In Lille, there's a similar kind of scheme that's launched in the early 1930s. They have two quite old hospitals, the Charité and Saint-Sauveur, and they have a large hospice, which is very old. And Mayor Salengro, who's a sort of big French socialist celebrity, local politician, ends up as Minister of Interior Minister during the Front government of 1936. He launches this city edification program in the early 1930s. It's going to make Lille beautiful as kind of the beautiful city of the north. And it includes replacing these hospitals with a new super hospital again. He employs, without telling anyone really, without telling the general public, he employs a French-American architect called Paul Nelson to produce a plan for him. And Nelson's plan is revealed at the beginning of 1932, and it is this incredibly modernist thing. It's a 22, 25-story buildings with a variety of other high-rise and low-rise around the site. It's going to pull out the hospice. It's going to be a training school, and it's going to be a big general hospital, TB center. Everything is going to be in this super location. And you can see from this site how the kinds of things that are going to be involved: two 25-story blocks, hospice in the shape of a cross, a hospital block including a medical school in the shape of an open book. There'll be a private hospital, there'll be maternity, there'll be convalescence, nursing. Everything is going to be on the single 30-acre site on the edge of the city of Lille. The plan collapses amid much opposition, and we'll come back to how that happens in a minute. So part of the reason why the Lille plan collapses is to do with finance. So how are you going to fund a new hospital? Well, in England, voluntary hospitals, as I've said, have to raise their own money to do whatever they want to do. So for a big capital project for a new hospital, they've got to raise that money themselves. So there's a good plan which actually develops in Birmingham, the Queen Elizabeth Hospital down at the bottom here, designed by an American architect, which raises £600,000, which is a phenomenal amount of money in the 1930s, to build a hospital, and it raises it through private finance. Well, it's not private finance. I mean, they're given money by private individuals, but they're mostly large-scale industrialists. Birmingham's a big industrial centre. They managed to tap into the wealth of those large-scale industrialists to finance this hospital. What they do in Sheffield, where they do have some large-scale industrials, but the city is in economic decline. So instead, they create this really kind of novel model where they get three different types of funders to come together to pay for this £1 million appeal. So the traditional private subscriber, the wealthy person who puts in £1 or £10 a year to the scheme, local businesses who they try and draw in to give large donations, as they've seen down in Birmingham, and then the workers who are already involved in a scheme, and the idea is that those workers will give an extra penny a week on their insurance scheme in order to pay for this. So 250,000 working class contributors will also provide a penny a week. Local state does nothing. It's not involved really. In fact, it gets very annoyed about this and falls out with the voluntary hospitals as a result. So in the English model, it's very much a private initiative. It's a voluntary initiative, and they're using very novel new ideas to try and pull this money together with a plan to raise £1 million, which by 1940, they got to about £500,000. They had done very, very well. In France, the system is more what you might expect. Half the money comes from central government, quarter of it comes from the department, the regional government, 12.5% from the city and from the people who run the hospitals. But it could be contested. The Nelson Salengro model for Lille was priced at 400 million French francs, a lot of money, maybe somewhere in the region of a million, more than £1 million British pounds, certainly at that point. The potential cost, and the French Ministry of Health just says no, they're not willing to fund that. They've put a ceiling of 250 million on. They also, various sides argue over who should pay for what. So those allocations of money, there's lots of debate about which part of the operation, which part of the plan is met by each of these different organizations. Bringing in a medical school allows Ministry of Education to come in, and in fact, they're the first kind of big chunk of money, and they see the medical school built largely ahead of much of the rest of the hospital when it's finally done. So the financial models are different. One is very state-focused, the other one is very private-focused. The other difference between Britain and France comes around design, and probably a bit more predictably. That question arises in the 1930s about how do you replace the pavilion model of a hospital, that Grange Blanche model. Well, there are models, there are ideas coming out of America. You've seen this in the Nelson plan. Skyscrapers are very important. But the French local, particularly French right wing, rebel against the ideas put forward by Nelson. They rebel against an American coming with his foreign skyscraper idea, and instead launch a big campaign against it. His idea is binned, and instead they get a conventional kind of way of raising finding the architect for the Lille project. So one of the ways in which they're looking now is at what could be a French model of modern. And this is very much Jean Valter's design for the Beaujon Hospital in Paris, which opens in 1933. It's 11 stories high, it has a maternity hospital, it has French windows at the end of each of those stories, a little balcony so patients can be wheeled out, and it only cost 100 million francs. So it's a kind of cheap at twice the price. So in Lille, launch a traditional competition after the failure of the Nelson plan. The entrants had to design a hospital, and they had to be French. They had to have designed a hospital before, and they had to be French. And this was really important. It was a very nationalistic competition. And the competition was won by Jean Valter, who'd done Hôpital Beaujon. He used some of his ideas from that. And you can see down at the bottom here, this is his plan for Lille, which looks very similar to Beaujon. It's going to be 10 stories, it's going to have a medical school, plus maternity, hospice for elderly. It's going to be very similar. So he draws some of the ideas from the Nelson kind of footprint for this, but makes it more French, more acceptable to the right wing. And then it kind of gets the go-ahead, starts building in 1935, runs actually, it's one of the first things that kind of really takes off after the Second World War. The hospital is completed in 1953. And although the design changes a lot, you can still see the kind of similarities here. You can still see those piers with the kind of stepped piers. He's made it more circular than crosses, but the idea of the book and the cross are still there. And it's 10 to 12 stories high. So it does get built, and it's interesting. It's not quite the first super hospital in France, but it very nearly is. In England, things are a little bit more conservative, though interestingly, The design that comes out for the Sheffield Hospital in 1939 attracts a number, the competition attracts a number, 7 different architects compete. The winner has already produced a number of hospitals. It's very modern design, and it's comparable to the Soda Hospital in Stockholm, which is often seen as being like, you know, why didn't the British do this? Well, the British were very close to doing this. They just, the war intervened and it didn't get done. So the plan which is adopted has 10 stories. They'd had a previous 7-story miners' welfare block. For that, they'd noted that 7 floors is more conveniently worked than than a ward of 3 or 4 floors. So they're already beginning to see the advantages of height in terms of how you deliver services. They save time, the supervision was easier, higher wards are quieter, the air is better. So there's lots of reasons why you build up, and you build up particularly on that model of a flat back with the wards coming off. So the multi-story block of circa 10 floors is replacing the pavilion style. So what have we learned? Well, the new international movement in hospital building, what it's looking at is efficiency, integration, and scale. So you build up, you build more efficiently, and you build in an integrated fashion. So instead of having everything spread out across a wide space, pull it all together, stack it up, and make it much more efficient and effective by having the services across the back and bringing the patients out onto these spokes off the side. But that sort of idea is successful, but there's little consensus on what to build, would be built when or by whom in the 1930s. It's still a highly contested idea. That doesn't come easily, that kind of solution, nor how it should be financed. So as I say, the principles of the sort of roughly 10 floors, south-facing wards, piers for wards with services in the blocks behind. Who should pay was still an issue. In England, state support did exist for those municipal hospitals I showed you, those kind of quite modern-looking places. But voluntary hospitals, the acute services, were still going to be paid for at this point by public appeals, by donations from wealthy individuals. But then the war came along. It stopped building. The NHS then followed immediately on the back of the war. And one of the things that the NHS did not do was build any new hospitals in England for 20 years. It's a great idea, but one of its big problems is it doubles demand overnight without increasing the services at all, and has to spend its time for the first 20 years using its money to pay for the huge increase in demand for services. So new hospitals don't follow until the 1960s. Yet in France, where the insurance scheme is really kind of already beginning to provide extensive capital injections into their system, they make building new hospitals a priority, and that Lille project gets finished, and we see it as a sort of a bit of a kind of a flagship for the new republic, the Fourth Republic, that followed the defeat in the Second World War. And I have a feeling that's me done. So thanks very much.
Thank you very much, Barry, for your amazing paper. Quick reminder, after the 3 papers presentations, we'll have the debate. So please type your questions or comments in the chat of Zoom and in the chat of the YouTube. Now we welcome Kenzu Digermenklioglu. Sorry, Kenzu, if I miss. Kenzu is a doctoral candidate at the Technical University of Munich, the chair of architectural history and curatorial practice. She is currently residing and carrying her studies in Berlin, teaching online design history courses at a foundation university in Turkey, and working on her dissertation titled Prescribing Modernity, the impact of health and hygiene concerns on Turkish architecture during the early Republican era. This project is funded by the DAAD Doctoral Scholarships. Her scholarly research mainly focuses on the modernization of Turkey and histories of medicine and modern architecture. In addition to various conferences and seminar presentations, Kenzo is currently in the process of publication in the peer-reviewed journals and the revising process of a book chapter, which will be published in 2021. Kenzo, the floor is yours.
Yes, thank you for the introduction. I'm Cansu Değirmencioğlu. Hello, everyone. My talk is about the development of Turkey's first state-owned sanatorium, Heybeliada, as an architectural prototype and a social mechanism in forming the ideal citizens of Turkish Republic. I have based my evaluation mainly on the book titled Heybeliada Sanatorium Foundation and Development, which also gave its name to this talk, and was authored by the head doctor, Tevfik İsmail Gökçe, just before his retirement after 30 years of service. I believe Gökçe's account offers a uniquely informative history of how sanatorium buildings epitomized biopolitical discourses of power and how modern medicine united forces with technology and architecture in constructing modern societies. In November 1924, 1 year after the proclamation of Turkish Republic, the Heybeliada Sanatorium started accepting tuberculosis patients within a capacity of 16 beds. It was founded on Heybeli Island, the second largest of the Princess Islands, located 20 kilometers southeast of Istanbul. Server Kamil, the founding head doctor, was a former medic in the army, and Tevfik İsmail Gökçe was appointed as the deputy. 1 year after the opening, Server Kamil transferred his duty to Gökçe, and after being appointed as the chief physician, Tevfik İsmail Gökçe was sent on a trip by the Ministry of Health and Social Welfare to observe the sanatoria in Germany, France, and Switzerland for 3 months. Here we see the first building, which was previously a convalescent home owned by the military school. When it was handed over to the management of the sanatorium, according to Gökçe's accounts, the building was in an extremely poor condition and did not have enough room for its purpose. So the dining hall also had a therapeutic function, you see here. And here is a very modest place they used for open air rests in the beginning. The cure terraces you see here were added 2 years after the opening. Having narrow financial resources and poor physical condition in the beginning, the sanatorium was to go through an exhaustive development process, much like the formation of the country. As you see in these maps, the expansion took place in many stages, and by 1955, the complex had taken its final shape as a landscape of health, including 2 main facilities based on the pavilion plan hospitals, 1 nursing school, and the rehabilitation center, in addition to various site functions. While the Pavilion B, the Women's Pavilion, was designed by a single architect, Rebi Gorbon, and built at once in 1946, the first main building, Pavilion A, was a result of 9 years of work. Here we see the construction stages of the Pavilion A, which was the first main building. The process was divided in many stages, both horizontally and vertically. For instance, section 3, 4, and 5 later were added new stories on the top, while the inpatients still occupied lower stories. Considering these many stages and the noise and dust coming from the construction areas, probably Pavilion A was not an ideal setup for TB patients, tuberculosis patients on occasion. In charge of all this construction and planning work, head doctor Gökçe proudly mentions how they managed to level the floors evenly when all the units were put together, except for the first block, which was already there, and how he envisioned almost every step from the beginning. These pavilion plan buildings featured terraces, large windows, and plain surfaces, which were the signature features of the modernist discourse of interwar architecture. Meanwhile, the modernist Turkish architects were promoting European modernism through rationalist and hygienic aspects such as sunlight, fresh air, functionality, and sanitary surfaces. Incorporating such concerns, Heybeliada Sanatorium was an embodiment of modernist discourse in architecture. Moreover, by taking the sick beds as the building blocks connected by technological systems, the sanatorium demonstrated a concrete example of the link between form and function. Gökçe was the one who made the decisions for a significant part of the building materials, such as wall and floor coverings, or even the furnishing. As the head doctor explains in microscopic detail, the floor coverings in patients' rooms were linoleum, and the walls were painted with oil paint up to 1.5 meters high. Such choices of material were presumably based on Gökçe's travels to European hospitals and sanatoria. In the operating room, for instance, he had been inspired by a French institution. To demonstrate his special interest in detail, Gökçe wrote, and I quote, "Taking the initiative, I had the walls of the operating room covered up with colored matte tiles up to a certain height, which was quite unusual for us until then, and had the rest of the wall and the ceiling painted with oil paint in the same color. This color is purple, and the tiles are the same as those used in the operating room of the high-rise Beaujon Hospital in Paris, which has just been mentioned by Barry in the previous talk." Gökçe continues, "The floor is covered with blue ceramic tiles. Another feature of our operating room is that there is no door to the corridor. By ensuring access from the adjacent room, the operating room is isolated from the corridor, and thus we are separated from the curious patients as well as the dust and noise of the corridor. The reason I am recording this is that I have recently witnessed the drawbacks of this issue in a newly built hospital. In 1948, Gökçe drafted and proposed a guideline of regulations and standards for the state sanatoria and included such details on spatial aspects. Although it did not become applicable for the remaining institutions, Gökçe, a very vocal and figure and an authority in TB struggle, had the chance to offer this know-how to his colleagues in various publications and conferences, in the absence of any architects specialized in hospital design. In the press, Heybeliada Sanatorium enjoyed the reputation as a technological wonder with a capacity to compete with its European counterparts. This enthusiasm resonated with the technocratic beliefs and the admiration to self-achievements in technology. Numerous photographs featured in Gökçe's book depict X-ray clinics, pneumothorax devices, and the most high-tech rooms of the facility. On the other hand, a significant part of the technical equipment was custom-made due to the limited financial resources. For instance, Gökçe designed a custom pneumothorax device, which was patented to his name, a custom-made disinfection machine, and a garbage furnace, which was inspired from a Hungarian hospital. As he could not afford to buy one, Gökçe designed and had a technician build a similar version of it. Proud of his innovative solutions, Gökçe featured the drawings of the furnace and even a photograph. In a way, this was a real-life example of the regime's "we will make everything by ourselves" slogan, which was used to promote the achievements in the industry within the self-enclosed economic policies. So I included these images from an applied arts exhibition to give a brief idea about this zeitgeist. Now, I would like to turn to an analysis on how this institution functioned as a social mechanism. TB was globally described as a social problem and associated with poor living conditions, and in Turkish context, it was initially identified with ignorance and socially irresponsible behavior. What was expected from a TB sufferer, therefore, was not only to stop spreading the disease, but also be socially conscious about it. There was no effective medical cure during the period I explore, and the capacity of the public sanatoria in Turkey was way under the demand. The overall capacity problem in the state hospitals for TB patients was frequently featured in the press. Hence, the maximum amount of time an inpatient could spend in Heybeliada was limited to 3 months. Moreover, most of the inpatients had the chance to be hospitalized here after months or even years of waiting in the line, meaning that the disease was already in a later stage. So 3 months was naturally not enough for such treatment. Reflecting on this issue, Head Dr. Gökçe enunciated the main purpose of the sanatorium as to adjust the TB patients to proper ways of living outside the sanatorium, and secondly, to educate the patients about the sanitary practices to prevent them from being a threat to the well-being of the society. This brings us to the social role of this institution, which is the formation of the ideal citizen. Civilized, secular, robust, well-behaved, and beneficial. For the Republican ideology, the civilized citizen was enlightened and well-mannered, with a tendency towards the Western culture. To impose such values, textual, visual, and audio media was utilized extensively. Likewise, Heybeliada Sanatorium incorporated libraries, two multi-purpose halls which functioned both to entertain the inpatients with movies, but also were used for lectures and conferences to educate them, and a centralized sound system. During leisure times, dining or sun cure hours, either music or some lectures were broadcasted to the patients, not only to save them from boredom, but also to elevate their cultural level. Secondly, the patients encountered with Western manners, such as dining etiquette, eating at high tables, using forks and knives properly on an everyday basis. Furthermore, the sanatorium bolstered the secularizing role of modern medicine by teaching the patient about scientific background of the disease, showing that the TB was not destiny, but a medical condition caused by a specific type of germ, and that the patient could have a control on it. The body was no longer in patronage of religion, but rather it belonged to positive sciences and was medicalized, measured, divided, and observed constantly by the medical gaze and technologies. And on everyday basis, body hygiene and therapeutic practices and cultural activities replaced the religious practices. The patients were also introduced the concept of sanitary living and the importance of keeping their everyday environments clean, orderly, and rational. In the rooms they occupied, there were no curtains or heavy textiles. The windows were always left open, and the choice of wall paints and flooring materials expressed contemporary hygiene concerns. As part of the tuberculosis prevention education, such sensitivity about spatial materiality was desired to be taken home later by the patient. Meanwhile, the authorities in Turkey were in favor of removing the window lattices of houses, and columns in popular journals promoted airy, sunlit, and sanitary homes. Typical for the 20th century regimes, visuality played an important role in reshaping the nation. This required the new civilized man not only to be in good health, but also look healthy, happy, and robust. Considering the common depiction of tubercular people as pale, melancholic, depressed, and weak, I believe the struggle with TB also challenged this look, not only to improve the image of the national body, but also to reintegrate the tubercular people into society. One reporter from magazine of TB Struggle Society visited Heybeliada and recorded how he was pleasantly surprised by the looks of the patients and impressed by the plenty of food that was being served 4 times a day. He wrote, quote, one has to be a medical doctor to tell whether these people are sick or not, end quote. As the reporter approached an impatient who was eating his meal with a great appetite and shared this fascination, the patient replied, quote unquote, God save our state and our nation. A side note, these photographs are taken from a different magazine article, but the concept is almost the same, and it is the Heybeliada Sanatorium as well. After they had recovered, or at least gained a certain level of awareness and left the institution, the patients were supposed to be beneficial to the nation and to the economic growth. The statistics show that most male patients were sent there by their employers so that they could get better and go back to work. On the other hand, considering that the patients often did not fully recover, many perhaps they should not have returned to their original jobs. In other words, we can think that this application brought a temporary solution that focused on economic development rather than the ultimate well-being of the individual. Only in 1954, a rehabilitation center was built in the complex and put into service to educate the recovering patients about more suitable occupations for their conditions, such as watch repairing, typewriting, and oil painting. The distribution of the amounts of beds for different sexes, on the other hand, reveals interesting information about unwaged labor. In the chapter featuring the patient statistics, Gökçe included the number of male and female patients. As it is seen here, there is a significant difference between the two. On this issue, the head doctor wrote, and I quote, "The reason why the number of beds is kept less for women is that the number of applications is always lower for women. For this reason, we are in favor of calculating the ratio of male and female beds in the new institutions to be 3:1. He continues, "However, this does not mean that the disease is less common in women. This is mostly because women cannot leave their homes and children due to the social circumstances." Gökçe expressed no displeasure or criticism on this issue, which I believe exemplifies the gender norms in the society and division of household labor, as well as Gökçe's paternalistic mindset. In a lecture he gave at the sanatorium, Gökçe legitimized his strict rules and authoritarian stance by these words, I quote, "You can be sure that the sanatorium is my second home, and this applies to all my friends. We see you all as family members. Equally and very closely, we concern ourselves with your joys and sorrows. My sincere toughness in disciplinary matters is only for your own good. Even though I feel bad about it, I make no compromises on discipline in order to protect the benefit of the society, because this is my duty. Indeed, it was the public peace that mattered most." This attitude surfaces in another chapter where Gökçe accuses pessimistic and depressed patients of upsetting the others and disturbing the peace within the boundaries of the facility. Like a germ infecting the body, the ungrateful patients pose a threat to the organism. To enhance the collaboration of the patients, the head doctor opted for acquiring an impression of domesticity and softening the institutional feeling in the material setting of surrounding the patients. I have 2 minutes left, by the way, I'm sorry. For instance, the rooms were equipped with individual wardrobes to enable their occupants to bring a few personal belongings, and the patients were at liberty to wear their personal clothes. Moreover, they were not addressed as the patients, but rather as the guests. This photograph depicts a 5-bed inpatient room from Pavilion B. As it is seen here, the guests were allowed to personalize their everyday environment within certain limits. In popular media, The sanatorium was often pictured as so not like a hospital, but rather like a hotel, far from the chaos of the city, where people looked happy and healthy, enjoyed lots of good food, fresh air, and rest. Almost like a heaven on earth, or in Foucauldian terms, a heterotopia. Nevertheless, the facility had an opposite image for the islanders, which exemplifies the common attitude towards the tubercular in society. In a newspaper article, the author quoted a friend living on Heybeli Island who accused the sanatorium of spreading disease, bringing death to the island. To conclude, until its closing in 2005, the sanatorium continued to host patients as a chest diseases hospital. In 2018, the conservative ruling party assigned the property to the Turkish Directorate of Religious Affairs, sparking new debates on the sanatorium's possible reuse scenarios. As a response, the Turkish Thoracic Society held a petition on change.org in 2020, suggesting the facility should be repurposed as an isolation hospital and a medical museum. In addition to its therapeutic function, Heybeliada Sanatorium has been an object of regimes and their distinctive political discourses since the day it was opened. Awaiting its destiny, today, the complex stands as a cultural landscape for the collective memory formed by Republican ideals and the precious artifact of history of medicine. Thank you.
Thank you very much, Kensu, for your very interesting paper. Finally, we'll have our third and last paper. Will be presented by Hongdeng Gao and is titled Medical Governance Contest over Governor Hospital Health Activism in New York City's Lower East Side, 1956-1972. Hongdeng Gao is a history PhD candidate at the Columbia University. Her dissertation, sorry, my notes disappeared. Her dissertation examines how Cold War geopolitics and grassroots activism in New York City improved access to healthcare for underserved Chinese New Yorkers in the last 20th century. As a dissertation fellow at the Consortium for History of Science, Technology and Medicine, Hongdeng worked as a researcher consultant for the New York City's Department of Health and Mental Hygiene, and as an intern at the American Italian Cancer Foundation. Before pursuing a PhD, Hongdeng co-founded Health Bridges, a grassroots initiative based in California that trains multilingual college students to serve as health advocates for patients with limited English proficiency. You have 20 minutes.
Thank you so much. Can everyone hear me okay?
Okay.
Perfect. Thank you so much for the introduction, and thank you everyone for coming. The question that I hope to address in this paper stemmed from my experience living in Manhattan's Lower East Side neighborhood, which is this area that you see on the map bounded by the red lines. In New York City, municipal or public hospitals provide important safety net care to low-income, uninsured or underinsured patients. In fact, the city has one of the largest and most generous public hospitals in the United States. But in the Lower East Side, there are no public hospitals. When my immigrant parents and I lived in this neighborhood and needed surgery or hospitalization, we had to make several bus transfers plus walking for another 15 minutes or so to get to the nearest public hospital. Through some initial research for my dissertation, one of my dissertation chapters, I found out that this was actually not always the case. For much of the 20th century, the Lower East Side had one municipal hospital called Governor Hospital, which is represented here by the X symbol on this map. Governor Hospital first opened in 1885 as a 50-bed, 3-floor municipal hospital on Governor Slip and Front Street. But an increase in demand for services and a large fire led to the construction of a new hospital and a larger one at 621 Water Street in 1898. From 1898 to 1961, this new Governor Hospital provided both inpatient and outpatient care to tens of thousands of poor and working class Lower East Side residents, including European Jews, Italians, Puerto Ricans, and Chinese immigrants. Many of its patients worked in factory and service jobs and lived in crowded housing that made them vulnerable to illness and injury. So my question was, why did Governor, such an important hospital to the community, close in the early 1960s? And in this paper, I would like to share with you just some of my findings. In particular, I will be looking at a moment in US history when changes in modern medicine really brought about a crisis in New York City's public hospital system, and when city officials, health planners, neighborhood activists debated about and fought over how local medical institutions should be planned and operated, and who really gets to enjoy the fruits of the post-World War II medical advances. So what happened in 1960 or around that time? Well, New York City public hospitals were facing a crisis. As you can see in this New York Times article, it reported that conditions at New York City's municipal hospitals range from leaking roofs and long delay services to dwindling personnel and shortages of supply. But actually, as early as 1953, Governor was already facing outdated structures and facilities that limited its care. As a local principal reports on his visit to Governor, he observed extremely crowded spaces that needed painting and updating. The ambulance actually could not in any way approach the building proper because the inclined pavement was made for horse and carriage and not for the modern ambulance. So he's saying that the hospital was turning patients away and it needed a new building. These conditions at New York City's public hospitals were really brought about by a number of factors. Starting in the 20th century, but especially after the Second World War, private hospitals in New York City were updating their facilities with the sophisticated and expensive technology that one associates with modern medicine, and also created numerous specialized departments. They also established affiliations with private medical schools, forming what are known today as medical centers. So in contrast to public hospitals, private hospitals in New York City were better able to attract medical graduates who were looking for residencies and internships in specialized areas, as well as self-paying and medically insured patients. Private hospitals dealt with all these increase in expenditures by taking fewer charity patients or patients who could not afford to pay their care at all, and shifting these patients and associated costs to public hospitals, whose mission, as historian Sandra Updike has nicely put it, was to never turn anyone away. In response to this crisis, New York City's Mayor Robert Wagner asked a group headed by an investment banker, David Heyman, who's pictured here on the left, but mostly consisting of physician administrators from the region's private voluntary hospitals and medical schools, including Dr. Ray Trussell of Columbia University, to come up with a reform plan. The group eventually designed an affiliation plan in which the city would basically pay its private medical centers to have control over and staffing and related services at its public affiliates. The plan promised to leverage the recruiting powers and prestige of private hospitals and allow more effective sharing of supplies in public hospitals. In 1961, Dr. Trussell became the city's commissioner of hospitals, and he basically implemented entire affiliation plan citywide. He also ordered the closure of Governor Hospital, which is the subject of my interest here, as well as a number of others that are in low-income neighborhoods that he deemed were unlikely to secure any affiliations with private medical schools. His rationale, as you can see in this 1956 report, was that Governor Hospital was already outdated and that it would not be able to attract any medical personnel to provide care. So rebuilding this hospital would be a waste of the city's money. Instead, he thinks that Bellevue Hospital, which is this hospital represented by the blue X symbol here, which is a much larger hospital at 26th Street and 1st Avenue, would be able to provide enough services for the entire Lower East Side population. And his rationale is that Bellevue Hospital already has affiliations with Columbia University, New York University, Cornell University, so it would be able to provide better care with the best personnel that one could ask for. So you really see in this time period the assumption among city officials and physician administrators that if a hospital does not have the latest technologies and specialized departments for inpatient care, its existence cannot be justified at all. You see a really different picture when you turn to the community and community groups like this one. So many Lower East Side community groups oppose the closing of Governor through sustained activism, and I would like to just delve into some of its legacies here. One example is the work of the Lower East Side Neighborhood Association, or LENA, which was a coalition of social and civic leaders from the community, including Helen Hall from the Henry Street Settlement House. At petition drives, rallies, and public hearings, LENA shared testimonies from its members that highlighted the difficulty of traveling very far for care, both inpatient and outpatient, especially for young mothers, elderly, and infants from the community. If the only city hospital below 26th Street closes. LENA also emphasized that the community had high rates of infant mortality, cancer, and heart disease. Individuals like Helen Hall argued that highly specialized doctors and technicians and expensive and elaborate procedures should really be reserved for the most intricate cases. What the community at large really needed was a hospital that's centrally located and that emphasizes preventative and comprehensive health services, as well as social and mental health and community outreach programs. So in 1961, there was a compromise by the end. The city's Mayor Robert Wagner insisted that the inpatient service still close, that all surgery and anything else that require hospitalization would be done at Bellevue Hospital or any private hospitals nearby. So I have a map here that shows two nearby private hospitals in blue triangles, and this is Bellevue Hospital up on top, and this is Governor Hospital on the bottom. But he gave in to LENA's demand in terms of keeping Governor's outpatient services. But these services, including home care services, ambulance, emergency room, would only be provided through an affiliation with a private hospital called Beth Israel, which is this hospital located around 14th Street. Reports on the citywide affiliation, including affiliation with Beth Israel, show that the benefits of affiliation really flowed in the direction of the private medical centers. Private hospital affiliates, including Beth Israel, used hundreds of millions of dollars in city funds at their own facilities for payroll padding, for salaries, for supplies, while regularly dumping patients, undesirable patients who were uninteresting for clinical research or things like that into its municipal affiliates. But one heartwarming thing was that Lena, through its continued input and pressure, was able to help develop Governor into one of the first neighborhood health centers in the United States before the concept was even adopted in 1965 nationally. Governor really was able to emphasize primary care and continuity of care. And the unit actually employed community organizers and door-to-door health workers to gauge common problems in the area and encourage more use of Governor's services, effectively really blurring the boundary between the clinic and its patient population. And in the next decade, Lena continued to help foster participation of neighborhood activists and layperson in the planning and operation of Governor with very tangible victories. For example, in the spring of 1967, the city eventually agreed to build a new hospital, a new Governor at 226 Madison Street with not just outpatient, but also inpatient services, with the caveat that it was still going to be through an affiliation with Beth Israel Hospital, and that no surgery or obstetric services would be provided at Governor. So there was another kind of compromise that you see here. But another interesting finding from my research was that the Health Council, Lena helped form a community watchdog group called the Lower East Side Neighborhood Health Council South, which was a community watchdog agency consisting mostly of users of Governor's health services as well as health professionals from the community. And as you can see from this poster, Lena, the Health Council really served as a community liaison between the consumers of Governor as well as the Governor administration. It was able to relay information about existing services as well as any complaints, suggestions for improvement to the hospital, hoping that the hospital would then be able to better tailor its services to what the community and its demographics needed. And lastly, I would like to just share with you some of the other advances that the Health Council was able to make through its work. One interesting finding was that the Health Council workers really were able to make Governor services more inclusive, especially for the community's growing Black, Puerto Rican, and Chinese populations. So one worker was Paul Ramos, who is pictured on the right here. He was of Puerto Rican and African descent and worked in the community before joining the Health Council in 1969. He saw high rates of fatalities among Black and Puerto Ricans from uterine cancer, sickle cell anemia, lead poisoning, tuberculosis, and venereal diseases. He attributed these health issues to substandard education, housing, polluted air, and garbage-strewn streets, poor nutrition, psychological stress, and strain due to unemployment and racism, as well as issues in the healthcare system, such as inadequate follow-up, fragmented care, and lack of community programs. And as you can see from this quote, Ramos really likened the way in which city officials and physician health planners who were really at the top of the medical hierarchy denying the community of decent health care to the exploitation of plantation workers, plantation owners, and believed that residents from the community should have the right and also the power to take their health status and destiny into their own hands. He eventually helped found a mobile van that screened diseases that were prevalent among Black and Puerto Rican populations, and the van eventually developed into a community health center called Batanzas that still serves in the Lower East Side today. Another worker was Thomas Tam, who was a Chinese immigrant to New York City, who joined the Health Council in 1971. He realized that the #1 issue for the Chinatown community, the Chinese population in the Lower East Side, was language barrier. He noted that many Chinese people have never heard of Governor because with 20% of patients being Chinese at Governor, there were only less than 1% of workers who can speak Chinese in the hospital. So he, in 1971, worked together with Ramos and others from the Health Council to mobilize for the city to hire more multilingual personnel, individuals who speak Italian, Spanish, Chinese, to be hired at the new hospital when it opens. So you see on the picture here on the right, they were really able to mobilize a diverse group of people, including elderly Chinese seniors who normally don't participate in these kind of protests, to really take their health and the distribution of health resources locally into their own hands. Thomas Cham also spearheaded a summer street health fair, really taking health resources and screening into the community. And the health fair was able to collect a lot of data, which up to that point was non-existent, on health status of Chinese population. And the health fair eventually led to actually another health clinic being permanently founded in Chinatown that still serves the community today. So what happened to Governor at the end? Well, the new governor was able to open around 1972 at 226 Madison Street. And the city agreed to hire 19 people from the community who spoke languages such as Chinese, Italian, Spanish. However, the new governor still relied on Beth Israel for staffing and related services, which gave Beth Israel wide-reaching power. So Beth Israel was able to decide how many doctors it would assign to the municipal affiliate and where to use the hospital's budget. And they actually continued to reject many charity patients who were sent from Governor to Beth Israel for things like surgery and obstetrics, and really offered second-class treatment to these transfer patients. Eventually, Governor closed in 1975 as a result of the city's fiscal crisis, and it became a skilled nursing facility. So just to conclude, I think the story of Governor kind of raises several questions as well as lessons. I think its history shows the importance of having community representation and decision-making power over how local hospitals and clinics are planned and operated, so that they are more responsive to the needs of the community. But I think the work of Lena and the Health Council also suggests some limitations to such involvement, especially if the public or the community only has to some extent advisory and lobbying roles and no real mechanisms. So my second question would be, how do we hold private medical affiliates who get public funds from the state, from the government, to take care of patients accountable for using these funds? And then lastly, could there have been alternatives to the affiliation plan that the city implemented in the 1960s to resolve the crisis brought about by changes in modern medicine? How can the state develop incentives to encourage more medical graduates to work at public hospitals rather than the already well-resourced private institutions? And I will end there, and I look forward to your questions.
Thank you very much for your presentation, Hondeng. Now we'll start our debate, and please type your questions or comments in the chat, Zoom chat or YouTube chat. We have already 2 questions in the chat, but I will start asking a general question to our 3 speakers. As our session is called The Politics of Modernization, I would like to ask you to comment how can we characterize this idea of modernization? what mainly define this modernity in each of the case studies that we see in this session. If you want to start, Barry, we can start in order.
Okay, yeah, that's fine. Yeah, I was just trying to not kind of jump in and go first. Yeah, I mean, I think it's specifically in the case of mine, I think there's an interesting distinction between a wish to be very modern and a need to manage the politics of that. So as we saw with the case of the Nelson plan for Lille, you know, this was a super modern idea, which to some extent the population wasn't ready for, whether it wasn't ready for it because it was too radical a plan, or whether it wasn't ready for it because they didn't like the price tag, or whether they weren't ready for it because they didn't like the politics of the person who was floating it and the kind of the challenge to French nationalism that it encountered. So I think one of the, yes, so for me, certainly in that interwar period, and probably it carries on into later periods, is that idea of an international modernist movement, which is neutral, and the reality of localities, which actually have very specific or very ongoing architectural design ideas, which don't necessarily fit into an easy kind of international model. And I think what you see in Britain is a kind of version of that, which is, one might argue that a lot of what Britain does when it comes to modernity is a very gradual approach. You know, it takes things, it's a piecemeal, it's bit by bit. And the idea that comes out for the Sheffield Hospital, it's adopting new ideas, but not in a very modern way. It's modern in its efficiency and its ideas, but it's not necessarily modern in its external style. So, I mean, I think that there are a lot of politics here, and some of it does float around that idea of there being an international modernism, which is not actually a general currency in the 30s and 40s. And it's really interesting to hear the way in which Turkish medics are using ideas from France, from Hungary, and from other countries, but trying to make them local as well, which Radio 2 link. Yeah.
Yeah, I can follow from here. So in my case, yes, it was more like a perception of modernity by the government in the first decades of the Republic. So in Turkish case, it was the modernity is, yeah, almost all the scholars say the same thing. It was a top-down modernization. It was sudden. It was a political decision. So okay, we do modern now. it was kind of like it, because yeah, of course there are continuities with late Ottoman Empire in during the 19th century. We see attempts and ideas sparked in Ottoman period, but in the Turkish Republic it became an political discourse. So in my case, the sanatorium either reflects or either reproduces these discourses in many ways. So as the reflections and representations, we see that even with the gender roles or even the head doctor's role is, he takes a similar role like the founder of the country, Mustafa Kemal Atatürk, did. He is like, okay, now I'm starting from the scratch, and with all the limited resources, we will make everything. So there's this phrase like Westernization despite the West for this period. So they're okay with using the devices and techniques and knowledge of the West, but they still want to keep the pride and the cultural values of the Turkish culture. So in the head doctor's narratives, we see that he is also proud of how he adapted the knowledge from French and German institution. He is proud of he brought that knowledge, and sometimes he could manage to brought some technical equipment from there. But he is also proud that he was able to find solutions that do things his own. And in the end, there are some notes about also some experts from French institutions and German hospitals visited our institution, and they were amused by our facility. And this dichotomy kind of reflects the perception of modernity of the period. Yep.
And for me, I really enjoy hearing Barry's presentation because I think there were similar questions about how to finance modern hospitals, right? Where the money would come from. And in this case of New York City, you really see in order to kind of adapt to these changes in modern medicine, private hospitals decided to shift its charity patients to the public hospitals. So you see kind of a divergence in mission after modernity came, because before then, everybody did not really see modern medicine as, you know, this great kind of life-saving thing until really after post-World War II. So both voluntary and public hospitals mainly serve poor individuals and not really middle class and anyone who had insurance, right? This all came afterwards. So you had a divergence in mission, but also changing ideas about citizenship and who really gets to enjoy the fruits of the medical boom, especially after World War II. And you see kind of local activism and protests demanding that ordinary people also get, individuals who are not covered by insurance also get the benefits of modern medicine. So thank you.
A question from Fritz Stross to Barry. Has research and teaching in hospitals had been a serious topic in architectural planning and financing?
Yeah, I mean, I think both in terms of when it was happening, it certainly is important, increasingly so. In my two examples from Lille and from Sheffield, in the Lille case, it's very clear. They're building a medical school with a hospital attached, or a hospital with a, you know, the integration is there from the very start in the plan. It's kind of reflects the commitment of a regional medical school. So integrating, you know, the patients and the teaching, very, very important. I mean, interestingly, one of the hospitals it replaces, it being France and the north of France, there are two blocks, one for the Catholic university and one for the secular university. So in the old teaching college, they have a hospital with two wings, and one is kind of staffed by Catholic medical students, and the other one is staffed by non-Catholic medical students, or by state medical students. So those one of the things that the new thing is trying to do, get away from that, build a new kind of modern, in that sense, modern idea of a hospital. Sheffield is interesting because the people who drive its development, in the end, it ends up being built in the city centre because the medics live in the city centre because they want to be close to the university, and they also want to be close to their middle class patients. So as that kind of triangle develops, is that middle class private patients live in the area, the university's in the area, and then the patients will be, well, the patients probably are not going to be in the area in the future because they're going to be moving out. So there's a very strong link, and the sort of senior medics decide on a lot of the plan for the new hospital, and it is driven by medical education, and it is driven by the convenience of medical students and nothing else. You know, they want to have a hospital that's near the university and so the students can move backwards and forwards between the two. But also there's an increasing understanding of research as part of that. And in Britain, you have a similar situation to the one that develops and emerges in New York, where you've got two sectors, one private sector, which does the good stuff, and one public service sector that does the rest. And one of the interesting things about the plans for this is that they are going to try and integrate that public sector around certain ideas. So it will be around diseases, infectious diseases, and education. It will be around, I can't remember, there's a second one, and then the third one, which was really interesting, was head trauma, because these are going to be working class patients who get their heads banged at work, and that was going to be dealt with by the hospitals, at the municipal hospital. But tuberculosis is the main one, and maternity is shared between the two. And there's quite a strong maternity research developing as well around pathology and puerperal fever and things like that. So yeah, so the answer is that in that sense, what's been far less done is historians have not taken much interest in this yet in terms of that integration of the two. I mean, I cover it a bit in my book, but it's not really a sort of a big theme yet.
From Anna Peterson to Kansu, what a wonderful paper. I know this was not part of the scope of your paper, but I was wondering if a similar educational outreach program was developed for Hansen's disease.
Thank you. Well, I'm not sure. I mean, the spotlight was obviously on clearly on tuberculosis, malaria, and syphilis in this period, but also there was a general propaganda about living hygienic and healthy. So I think this concerns of all of the airborne diseases. And I know that there were few institutions about treating the leprosy patients. But I cannot say that there was a special emphasis on it. So most of the education consciousness about tuberculosis came from the Society of Struggle with TB, which was founded in 1920s. So I just checked after I saw Anna's question in the chat. So the Society for the Struggle with Leprosy was founded in 1920, late 50s. So I think it came later. It's become a national discourse, propaganda later in the 50s, probably. Thank you.
Thank you. I want also to ask to Hongdeng, the community initiatives that you talk about. The hospital has voluntaries to work with the communities. They truly contribute to change or improve the relation between people and the hospital?
Do you mean if they were able to improve relations?
Yes.
So the question, the answer is complicated. To some extent, I think I highlighted some of the achievements that they were able to make. So, for instance, they were really able to get more bilingual personnel to provide such kind of services at the hospital, and also more community outreach programs. But at the same time, there were oftentimes a lot of tension between the administration and the workers, because they first of all, they were paid by the hospital, so they really had to oftentimes give in to that because they were being paid there. And so the individuals I talk about, Ramos and Thomas Tam, they actually went on to found those mobile health units and health fairs really on their own without really much kind of support from governor. So I would say that that's why I kind of have that ambivalent question at the end about limitations of community involvement and whether or not you need more kind of effective mechanism, maybe through state regulations or municipal government regulations, to make sure that the funds that Beth Israel and other private medical centers received were really going to be used for the public rather than private patients. Yeah.
Okay.
Thank you for the question.
Thank you. Other comments or questions? You share something with us, Barry?
Yeah, I was just, hopefully it's a picture that if you click on it, it will appear, but it doesn't look like it's going to, does it? Maybe it will. Oh yeah, it does. If you click on it, it pops up. And it's a sanatorium. It was in my original presentation, but then I cut it out because I thought I was going to talk too much. But it's of a sanatorium wing that's built in 1936 in Leeds. And it's kind of has all these classic aspects of a modernist, municipal TB type design feature. It has it's designed specifically for women, and it picks up on the ideas that you were talking about, that they have a problem keeping women in, because the actual treatment regime is supposed to be for a whole year. And you know, most people cannot stop working and live in a sanatorium for a year. And certainly, you know, married working class women with children can't do that. So they're trying to look at ways to encourage women, patients, to come in the first place and to stay when they get them. And so this is one of the ways in which they do it, is they design this very attractive modern building for them, 2 women per room, all south-facing rooms, nice tables and chairs, as you say, sort of an opportunity to kind of own the room whilst you're there. And then it's a lovely view as well. The view goes out beyond the city of Leeds. So there are these sorts of, and it picks up on that kind of modernist, internationalist ideal, but it's designed by the city engineer and costs next to nothing. They knock it up for £14,000. Sadly, of course, when the hospital goes out of business, nobody bothers with it anymore. And because it was basically brick and glass, it's all fallen down now, which is a shame. It's disappeared entirely. But you know, on that architectural level, it's often tuberculosis hospitals in the interwar period that are the ones that are most advanced, because they're dealing with a different kind of patient who's relatively static and might be more interested or more readily built in something that's driven by aesthetics rather than by technologies.
Thank you, Barry, for sharing it. No more questions or comments, so we'll finish our session. Thank you very much to all the 3 speakers and their amazing papers. We will now have a small break, like 15 minutes. We will return 5:15 to our last session. Thank you very much all.
Thank you.
Hello, everyone. Welcome back. This is our final session. If I look overly familiar to you, it's because, unfortunately, I am. So due to scheduling conflicts, Catherine will be unable to chair this session. So I have stepped in, I guess. So this is our final session, which is really exciting because when we put this conference together, I was really looking forward to this session, even though I know literally nothing about it. So I apologize in advance. But it's also our last session, which is very sad. But we've had such a great run of papers, and I know we will end on a high note. So that was not pressure. It's because I believe in you. So without further ado, let us get into it. So I'm sure everyone is so sick and tired of me saying this, but so we will run all the papers consecutively. I will introduce you and you will have 20 minutes on the dot. I will put up my hand like this and wave it. So try to, I'll leave my video on. So I'll do this so that you can see that you have 5 minutes. If I'm concerned that you're in danger of going over, you might see a 1 minute and it might make a naughty sign at you. And then you will conclude because I know you all did a good job timing out your papers. So after all of our speakers have concluded, we will have our debate session. As usual, please, if you are on Zoom, there's a little box down at the bottom that says chat, type your question into there so I can see it and then I will read it out to our speakers. Make sure if you want to address it to a specific speaker that you tell me who you want. I'm not a mind reader, but I will do my best. Also, please, general questions for all three are most welcome. If you are following us in the live stream, same kind of concept. You write your comments in the chat, which is on the right-hand side, and someone will drop them in the chat for me to read. So without further ado, let's get into it. Maternity. So our first speaker is Fritz Dross, which some of you might be familiar with. He's very distinctive. Hello, Fritz. So Fritz is an assistant professor of history of medicine at Friedrich Alexander Universität Erlangen-Nuremberg. I think I did better with the German than I did earlier today, so I'm going to give myself a high five for that one. Besides his research on early modern hospitals, epidemics, and urban health services, he is working on the history of gynecology in the 20th century, especially during National Socialism. So, knowing that, today Fritz is going to present a paper entitled Gendered Medicalized Spaces, Inside and Outside Hospitals in Early 20th Century Germany. Fritz, take it away.
So, just have okay. Sorry, can we change the papers, because I've just a brand new computer and I have to change something and I have to leave Zoom to allow it to capture the screen, which I'm just seeing in this second. So I'll be back in 5 minutes.
All right, so we will come back to Fritz. All right, not to worry, Fritz. Good luck. All right, so Kathleen, thank you for being a wonderful volunteer. So Kathleen Pierce. So Kathleen Pierce is currently a visiting assistant professor in the Department of Art at Smith College in Northampton, Massachusetts in the United States, which, by the way, has a beautiful campus in the fall. She received her PhD in art history from Rutgers University in May 2019. Her research focuses on the intersection of art and architectural history and medicine in the 19th and early 20th century French Empire. She is in the process of revising her dissertation for publication as a monograph. It will be entitled Ephemeral Surfaces, Skin, Disease, and Visuality in the Fin de Siècle French Empire, which will examine a broad range of objects from dermatological illustrations and wax-cast models to public health posters and avant-garde paintings to understand the relationship between the surface of the modern body and the surface in modern art. Her research has mostly appeared in medical history. In January 2020, in an article titled Photograph as Skin, Skin as Wax, Idexicality and the Visualization of Syphilis in Fin de Siècle, France. All right, first off, That was a beautifully written bio. I did not write any of that, and I was like, oh, I'm jealous of it. All right, Kathleen. Kathleen is going to be speaking to us on the paper entitled New Spaces for a New Midwifery at the Lying-in Hospital of the City of New York. Kathleen, if you would.
Thank you. And I just shared, so hopefully it's visible now. Good. So thank you so much for having me, and thank you all, for all the work organizing. I know this was an incredibly challenging time to put together a conference, so it's much appreciated. I'm going to go ahead and jump right in. So in early 1897, where we're beginning, the financier J.P. Morgan offered a gift of $1 million for the construction of a new hospital building to the Society of the Lying-in Hospital of New York, a charitable organization that strove to provide vanguard medical care for, quote, the destitute and helpless mother, end quote. The facility would be constructed on the lower Manhattan site that was already occupied by the society, the former Hamilton Fish Mansion. This was on 2nd Avenue between 17th and 18th Streets. While the mansion had only been purchased and converted into a hospital 3 years earlier, the space was already lamented as insufficient for the hospital's services. Morgan's patronage then arrived at a moment of transition not only in the life of the society itself, but at several interlocking registers that we've heard a bit about already during the conference. This includes new theorizations of vanguard hospital design, particularly the shift from the pavilion to the block plan, increasing specialization and professionalization in medicine broadly and in obstetrics specifically, a burgeoning awareness of Pasteur and Koch's germ theory and Lister's antiseptic procedures, and changing understandings of pregnancy, labor, childbirth, and postnatal care. The completed 1902 hospital, then, sits at the nexus of these intersecting cultural threads. In this paper, I center the new 1902 hospital as a case study, illuminating the productive and formative role that the built environment played in shaping the above discourses. While historians have thoroughly examined the general shift of childbirth from the homosocial space of the home to the heterosocial, professionalized, and impersonal space of the hospital, I contend that the architectural structure of the maternity hospital itself, which is to say the spaces chosen to be included or excluded from its plan, the physical organization of its wards, and its location within the city, is equally ripe for analysis. Through close study of the 1902 hospital's organization, I demonstrate that the building's plan made manifest physicians' efforts to professionalize obstetrics, mechanize the process of childbirth, and prevent midwives from practicing. These theoretical solutions for physicians, however, simultaneously transformed patients' understandings of pregnancy and birthing through the experiential space of the reorganized hospital. Unlike birthing in the home, wherein labor, delivery, and recovery all took place within a singular room, the hospital physically and temporally segregated labor, delivery, and postnatal care. While the larger project from which this research comes expands, and I'll just give you a sense, that bigger project includes thinking about the hospital's location within the city, especially in relation to immigrant communities in New York, connections across racialization, ethnicization, and childbirth, and the spatial allocation of workspaces for different categories of healthcare professionals within the hospital. In today's talk, I'm going to limit to focus on just one piece of the research, which is the newly codified spaces, wherein pregnant people would have labored, delivered, and recovered, and these spaces' connections to time, mobility, experience, and authority. So I want to begin by tracing the events leading up to the patronage for the 1902 hospital. The society did not have a dedicated space for the provision of care throughout the 19th century, but by 1894, donations from several philanthropists allowed the society to purchase the aforementioned Hamilton Fish property. The property situation within the larger context of the city appealed to the society's board of governors. They appreciated its central location and proximity to elevated railroad stations, surface roads, and crosstown cars, the primary modes of access for its projected middle and lower class clientele. And you can see the north-south raised railway station circled in red, and the crosstown station here circled in teal. The Board of Governors also lauded its adjacency to a public park, Stuyvesant Square. The verdant surroundings aligned with the contemporary knitting together of health and natural spaces, most clearly articulated for New Yorkers by mid-century debates around Frederick Law Olmsted and Calvert Vaux's work on Central Park. A few years following the purchase of the Hamilton Fish Mansion, we arrive at Morgan's $1 million donation, allowing for the construction of a new hospital. Morgan selected architect R.H. Robertson to create the plans, but required him to consult directly with Drs. James Marco and Samuel Lambert, physicians with leadership roles within the society, thus drawing a direct link between contemporary obstetric discourse and the hospital's plan. The new hospital would accommodate a greater number of patients, but also include a school of obstetrics, and therefore rooms for lectures and study, as well as student dining halls and dormitories. Additionally, while the society would continue to honor its founding mission of providing free care to mothers in need, the new building would also include several well-appointed private rooms for patients able to pay for care. The completed state-of-the-art 8-story building, which you see here, began receiving patients in January of 1902. In order to better illuminate the ways that space aligned with care, I want to walk you through a patient's experience of the hospital's built environment, attending closely to its plan, organization, and material composition. Patients could approach the new hospital in one of two ways determined by the urgency of their case. Patients who were physically able to travel to the hospital after the onset of labor, either on foot or by public transport, would arrive at the main entrance on 2nd Avenue. And you see a whole bunch of routes laid out for you there, lots of options. The entrance's location guaranteed that patients glimpse the green space afforded by Stuyvesant Square and the hospital's Renaissance Revival facade. Women unable to reach the hospital on their own could be transported by electric ambulance. And this would have led directly to the patient's receiving room via a driveway running through the building's ground floor. The ambulance was equipped to accommodate emergency surgeries or confinements if necessary, facilitated by the wide opening along one side of the vehicle and ventilation features in the roof. And you see it sort of opened up here. The hospital's 1903 report indicates that the ambulance made 30 to 40 trips per month, expanding the hospital's reach to populations that would not be able to access it any other way. The 2nd Avenue facade strategically combined aseptic and practical building materials with a moralizing aesthetic. Robertson incorporated both red brick and limestone on the east-facing wall of the steel-framed and fireproof building. Brick was considered to be a pragmatic building material for hospital construction. It was considered durable, attractive, and reasonably priced, leaving the institution money for the provision of healthcare. Glass comprised the remaining major material of the facade. Its qualities of transparency, seamlessness, and impermeability rendered it the, quote, king of aseptic materials, end quote, per architectural historian Jean Kazaki. In addition, Robertson's design featured decorative and moralizing classical elements, including columns, an arched entryway, and a pediment. In a reference to Della Robbia's roundels for the Ospedale degli Innocenti in Florence, Robertson included terracotta roundels with reliefs of swaddled babies on the spandrels and beneath the windows of the 5th and 6th stories. The specific allusion to the Innocenti roundels, coupled with the Renaissance Revival style and its classical reference points, belies the hospital's participation in broader networks of paternalistic, progressive-era reform in turn-of-the-century New York. Passing through the main doors, patients would have entered a lavish marble foyer, and I apologize for the not great photograph. This was me speaking with, it's now condos. So I was talking to the doorman there, trying to take some pictures. This is the best I could do. The luxe and decoratively carved marble that we see here recalls Anne Marie Adams' demonstration of the ways early 20th century hospital entryways mimic those of hotels, evoking the twinned qualities of hospitality and opulent domesticity. Patients would be guided to the receiving room on the ground floor of the hospital, here circled in green. Once checked in, their clothing and belongings would be kept in an adjacent storage room in purple here. From here, patients could be led to the waiting room, circled in pink, or one of 6 examination rooms to determine the progress of their labor, highlighted in yellow. Notably, an isolation room was placed just next to the storage room, intentionally segregated from other rooms by an extra hallway. While antiseptic techniques and germ theory were circulating at the time, Kazaki emphasizes that isolation facilities conceived at the turn of the century still focus on physically separating infected patients' air from that of uninfected patients. Admitted patients would then be taken up to the 4th, 5th, or 6th floors, whose plans were identical. Here, they would either enter the waiting ward, circled in blue, or the labor ward, outlined in green. Robertson placed these rooms beside one another and facilitated direct communication between them with a connecting doorway, yet they are fully circumscribed as discrete spaces, and likewise independently labeled in published plans, spatially circumscribing waiting and labor as distinct stages of the birthing experience in the new hospital. It was also at this point that patients systematically received prophylactic care in advance of delivery. Records of the process at New York's Sloan maternity from 1900 speak to the likely experience of lying in patients. Upon admittance, doctors or nurses would first administer an initial enema and antiseptic vaginal douche, wash the hair, nipples, and navel with kerosene, ether, and/or ammonia, and groom the pubic hair, where hair was clipped for pay patients and shaved for charity patients. Patients in labor received additional enemas every 12 hours and antiseptic douches at more frequent intervals. Physicians claimed to practice these preventative measures to stave off infection, primarily septicemia. And indeed, physicians were beginning to understand and develop procedures accounting for the links between aseptic conditions, sanitation, and disease prevention. Yet prophylaxis also provided additional, less benevolent opportunities for physicians and for students. The at times overly frequent application of these procedures offered guaranteed examples of preparatory practices for clinical education, a significant resource for a budding school of obstetrics. And in fact, returning to the basement story for just a moment, or the ground floor story that they labeled basement, there was a clinical instruction room located next to one of the examination rooms and connected to the basement story waiting room that might have been used for this or other educational purposes. Returning to the 4th, 5th, and 6th floor plans, once determined to be in the later stages of labor, patients would be transferred once again into the delivery room, here in purple. Delivery, more than any other stage of ante or postnatal care, came to be seen as the nexus of prophylactic techniques and professional posturing among physicians by the late 19th century. Historians often cite the contemporaneous professionalization of obstetrics and increasing use of interventionist delivery techniques by physicians as at least in part a response to another group who had long delivered pregnant people in the United States, midwives. 17th and 18th century women's deliveries were often attended by a friend or local woman who had herself experienced childbirth, some of whom emerged as community midwives. By the end of the 18th century, physicians saw themselves as sharing the profession with midwives, who might have been men or women. With the progression of the 19th century, however, physicians began to frame midwives as competition that threatened their practices. Unlike various diseases or epidemics, childbirth was a dependable medical event through which doctors could not only sustain themselves financially, but also build a customer base in family practice by skillfully delivering patients in front of family and friends. Historians have argued that physicians' desires to persuade women that they were the more skilled birth attendants led to an increased use of physical interventions in childbirth, including the use of forceps, prophylactic measures, and eventually the cesarean section, although these interventions largely did not lead to improved maternal mortality rates compared to midwives. As obstetric care came to be seen as skilled labor, the occupation, like so many others, became gendered masculine. Midwives came to be seen as a population beyond the reach of developing regulations in an increasingly regulated field. These factors, compounded by concerns over high infant and maternal mortality rates, led social reformers, physicians, and public health officials to point to midwives and their lack of training and oversight as the source of these problems. The society consistently disparaged the work of midwives in their own published writing, regularly labeling them as, and these are some of their adjectives, abusive, unskilled, uncontrolled, and perpetrators of malpractice. And this was in almost every annual report. The society even framed the elimination of midwives as one of its charitable missions, writing in 1899 that, quote, "the method pursued by the lying-in hospital is claimed to be the only one that can successfully prevent the practice of midwives," end quote. Returning to the hospital's plan, after delivery, patients receiving free care would be transferred to one of 9 main wards with 3 on each floor, circled here in pink, and infants would be relocated to one of 3 babies' wards, here highlighted in orange. Pay patients returned to private rooms. A nurse's room separated each private room from the corridor, providing an extra spatial buffer between paying patients and charity patients, while also ensuring speedier and more consistent care for wealthier patients. As this narrated passage through the hospital's floors and wards demonstrates, Robertson, Marco, and Lambert aimed to create a highly modularized built environment. Far from the single room of confinement, often occupied by lying-in mothers birthing at home, the 1902 hospital comprises the opposite end of the spectrum. Its interior spaces have been deconstructed, such that both discrete components of professional activity and patients' graduated experiences of birthing have been accorded individuated and dedicated spaces. This proliferation of segregated specialized rooms in the new hospital's plan thus atomized the process of childbirth. This atomization was communicated to patients on the one hand by their movement into new spaces for different stages of birthing. They now waited in the waiting room, labored in the waiting ward or labor room, or both, depending on their progress and how many other patients were at the hospital, moved into the delivery room for delivery, and convalesced in recovery wards or private pay rooms. But more than this, the above described permanent allocation of space lent authority to the professional division of birthing into stages, stages whose dividing lines are not natural nor fixed, but rather socially constructed and contingent. While midwives, physicians, and birthing people alike would have certainly recognized physiological shifts as they navigated birthing, by the late 19th century, physicians and medical literature specifically separated labor from delivery and recognized 3 stages of the former. The boundaries of these stages of labor, scholars have argued, were not placed in the interest of serving patients. Rather, they maximized convenience and efficiency for the obstetrician. The hospital's plan accommodates and, in fact, strictly enforces this mobility of patients' bodies. I want to return once again to the identical plans of the building's 4th, 5th, and 6th stories, which you see here. So if we look at this plan, the main staircase and main elevator bank leads out onto a hall that most easily leads to room 457, the waiting ward, or with a bit more maneuvering into 461, a small isolation room likely for patients admitted with infections. The waiting ward directly abuts a small vestibule opening onto room 455, the labor room. This room is inaccessible from the hall and only admits entry via the waiting ward or delivery room. Similarly, the labor ward leads directly to room 454, the delivery room, whose access via the main hall was also restricted. The delivery room opens out onto a hallway, leading directly to convalescence wards for both mothers and babies, such as room 450 or 451. Notably, rooms for students, such as 452, students' lockers, or 453, students' sitting room, also have direct access to the delivery room, demonstrating how the hospital's architecture encourages students to wait comfortably for and subsequently observe patients' deliveries. The cellular modulation of the maternity hospital naturalized the divisions of birthing only recently codified by 19th century obstetricians. In opposition to the stasis of home birth, birthing people here passed from room to room, spaces newly created to describe the distinct stages of birth that they would house. It's also worth noting that mothers birthing at home would have been responsible for appointing the lying-in room. This included selecting the room within the home most appropriate for confinement and acquiring items to facilitate birthing, such as linens and bedpans. While factors like class would have certainly limited the degree to which women had the time, space, or finances to make these choices, those laboring at home would have at least had some control over the room's appointment. By contrast, the spatial organization and accoutrements of birthing at the hospital were fixed, uniform, and outside the patient's control. This would have included standardized equipment, such like forceps, but also furniture, such as the birthing table, which was also designed to facilitate the professional engagement of physicians during hospital births at the cost of women's bodily autonomy. Thus, Robertson, Marco, and Lambert's allocation of dedicated spaces for discrete stages of birthing both transformed pregnant people's experiences while also bolstering the very professional authority that had named and defined those stages. The opportunity to teach future physicians and advance the specialty of obstetrics, coupled with the abundance of practical case studies afforded by such an institution, likely also appealed to physicians. It would seem that the 1902 hospital's design, however, also encapsulates its physicians' and administrators' anxieties at the intersection of degeneration, nativity, ethnicity, sexual reproduction, poverty, morality, an idea I will reflect on by way of conclusion. I'm sorry, my dog is ringing a bell. I hope it's not too disruptive. So by way of conclusion, the new hospital, supported by ambulance transport, offered medical authorities expanded opportunities to intervene in the pregnancies of poor migrant women who are often racialized to varying degrees. The very same groups often blamed for the degeneration of white Western society at the end of the 19th century. The hospital's division of spaces notably maximized the potential for surveillance and intervention, particularly as relates to these women's behavior and perceptions of pregnancy, childbirth, postnatal care, and even child rearing through prophylaxis, public health campaigns, and treatment. Recalling historian Tanya Hart's poignant observation, many physicians explicitly connected their, quote, desires to correct the birthing methods of migrating women to issues of assimilation and Americanization, end quote. It is also not surprising that this assimilation and Americanization would take the form of spatial and procedural atomization in the interest of efficiency, techniques so clearly linked to the rise of Taylorism and Fordism, which scholars have also demonstrated to be increasingly present in general hospital design in the early 20th century. At a moment of intense migration to the United States, and in a city whose port received the majority of these migrating families, we might understand the society's physicians and administrators as mediating, at a most fundamental level, the literal production and reproduction of new Americans. Thank you.
Thank you so much. That was fantastic. I'm glad your dog enjoyed it as well. Fantastic, thank you. So due to thematic reasons, we're pushing Fritz to the end, which he volunteered, for the record. It wasn't just unilateral on my part, though I have that power.
Now, Fritz, it's your turn. I'm not reintroducing you.
I'll try again.
All right,
so,
see what happens.
Does this work?
Good job, Fritz.
Okay. So first of all, Anna, many, many thanks to you, to your patience, for me personally, for taking over the job whenever any person felt not able to do his or her. So I think you chaired half a dozen of sessions within these 3 days. Well, wow. Remembering what I had experienced with the INHH, I think this is the first time that we have a special session on gender issues. And we're not only having one, but two, framing the whole conference, which is quite special, I think. And this is for the first time. And so I'm very grateful for being able to present a kind of experimental paper, which is a really fresh work, far from being finished. And I very much hope it raises quite a lot of questions to discuss. It's named Gendered Medicalized Spaces Inside and Outside Hospitals in Early 20th Century Germany. What I'm going to do, I'm going to present a random find, which had been a journal published from 1914 to 1933, the Archiv für Frauenkunde, which in English would be the Archives for the Study of Women, which is a very general title. And they had a very general ambition. So at first sight, there's no hospital in it and there's no space in it, but I will come to this. By the topics treated in these archives for the study of women, I want to reflect how gynecology and obstetrics had been trying, at least trying to turn into a very general study of women. And there is a very special connection of social gynecology and racial hygiene. And then I want to go a step back and try to reflect the hospitalization of birth giving together with the birth of gynecology and obstetrics generally as a male medical topic, which took place in the maternity and line-in clinic. And then I finally want to conclude with some aspects how the study of women and the hospital come together with a perspective on spaces of knowledge and spatialized knowledge. So this is the Archiv für Frauenkunde, Archives for the Study of Women. The first volume published in 1914, the year First World War began. The archives changed their name for several times. In the first years, they had been titled Archives for the Study of Women and Eugenetics. So you have the connection to racial hygiene already here. And then for the first years of the 1920s, they had been titled Archives for the Study of Women and Eugenetics, Sexual Biology and Inheritance Theory. And from 1924 up to 1933, when the publication ended, they had been called Archives for the Study of Women and Constitutional Medicine, in German Archiv für Frauenkunde und Konstitutionsforschung. The archives, most of all, are the work of Max Hirsch, who had been the founder, the spiritus rector, the mastermind, the editor, and personally wrote maybe 20% of all papers ever published over the time span from 1914 to 1933. He was born in 1877 in Berlin and had been in Berlin for the very most time of his life. He studied medicine and in 1911 became a specialist physician for obstetrics, gynecology, and surgery. And then he chose not to go an academic career, but to earn his money in a well-known private clinic in Berlin, which he later owned. So he had no financial problems over his life up to 1938, which is another story. And he engaged very much politically. In 1919, he got member of the Preußischer Landesgesundheitsrat, which was a council in Prussia, the by far largest part of the German Empire, counseling the politics. And in 1928, member of the Reichsausschuss für Bevölkerungsfragen, which would sound like Imperial Council for the questions of population. In 1933, he had to withdraw any editorial and political activities as being a non-Aryan, but he stayed in Berlin until he had been arrested by the Nazi secret state police when he fled to the United Kingdom, where he ended in Birmingham, first working as an unsettled specialist and later again became director of small obstetric establishment in Birmingham, where he died finally in 1948. Oh, wrong direction. So this is the program of changing gynecology, academic gynecology in the science of women, which had been published by Max Hirsch already in 1912 in preparation of his archives, which firstly had been published in 1914. And the program sounds in small quotations like this: the science of women is dedicated to women in all their relationships and expressions of life. Gynecology is only one province in the great realm of the science of women. How to reach this was the teaching of heredity, racial biology, and social hygiene, the regulation of reproduction. The nation and the race are fields of knowledge which are particularly close to the woman. From now on, gynecologists must not ignore these sciences. They promise answers which go beyond the narrow circle of the individual and concern the state and all mankind. And finally, it can be said without exaggeration that woman is the center of the entire economic life. She is producer of the most important good in the national economy, the organic life, on the quantity and quality of which depends the fate of all other economic values and the future of the human race. So this is the program of the Max Hirsch ideas of the science of women. And these are just to give a first idea of the connection between social gynecology and racial hygiene of the very first volume in 1914. We have again, of course, Max Hirsch with a programmatic article starting the whole volume. We have Alfred Grotjan, Eugenics as the Hygiene of Reproduction, which is a very famous eugenicist, German eugenicist from a left, a social democratic perspective. We have Franz Schacht, who had been the director of a School of Agriculture with a topic on breeding of the human race, because he knows from breeding from the animals he had to teach how to care for. And then we have Wilhelm Schallmayer, one of the most central eugenicists in German language, maybe like Francis Galton in the Anglophone world, with an article on eugenics and its relations to the cultural elevation of women, which ends like, the education of girls will have to aim at the fact that as wives, the higher they estimate their own value for the race, the more it will be to their credit to give the community or the race as an adequate number of offspring. The elevation of women to such a moral level would be the most valuable cultural elevation. It would provide the most reliable basis for permanent herding development of human culture. So this is a very vast spectrum of political homes, but they did not realize how there should and could be any kind of difference between social gynecology and racial hygiene at all. Just to give an idea on general trends in gynecology by some publications of Hugo Sellheim, who later on published in the archives of the Science of Women too, and who was a famous professor for gynecology and obstetrics in Germany, and even head of the German Gynecologic Society, who already in 1909 published like The Charms of Women and Their Importance for Cultural Progress. In 1911, The Mystery of the Eternal Feminine, an attempt at the natural history of woman. In 1913, The Sexual Difference of the Heart, and the heart is a metaphor here. So it's the place where feelings were made. The Production Limit and Decline in Birth Rate in 1914. In 1915, just with the beginning of First World War, What Do Women Do for the Fatherland? In 1970, Care for Reproduction. In 1924, Nature, Culture, and Women. And so on, and so on. So this is the common sense in gynecology to move over hospital borders and the specialist perspective on the cure of several but single events, disease events in the life of women. This is astonishing, as obstetrics and gynecology are maybe the medical discipline which most of all and only came out of hospitals. Going back about 100 years, a century, quotation of Friedrich Osiander, who founded Lying-in Hospital at the University in Göttingen in 1794 already, and who can be quoted with this famous quoting on this maternity clinic at the University of Göttingen. It would be judging very wrongly if one believes that this house is there because of the illegitimate pregnant women. Not at all. The pregnant women, be they subsequently married or unmarried, are here for the sake of teaching. The pregnant women and women in labor who are admitted to the house are regarded as living phantoms. This is the very origin of an academic obstetric and gynecologic part. And if you go further in 19th century, just to quote the famous case of Ignaz Semmelweis, this is truly hospital science. It had not been possible to make this out of hospitals, because what he made is getting numbers, putting them together, which is only possible in hospital. Semmelweis is science by numbers. And what is these women's studies and the study of women in the name of hospitals? They try to get the women in their most eminent role, according to them, giving birth back to the hospital as much as possible. In his maternity care and the foundation of social gynecology, published in 1931, Max Hirsch concluded, maternity care is not only focused on the protection of mother and child in individual cases, but moreover on the care for the reproductive performance of the whole. Pregnancy counseling should be combined with obstetric selection, with the aim of assigning pathological cases and those that are likely to have difficult birth to hospital care. Obstetric care requires the provision of a sufficient number of beds in maternity hospitals under the supervision of specialists. The aim of obstetrics must be painless delivery. Precondition, the mother and the child must not be in danger. The aim of obstetric care must be aseptic delivery. And of course, painless delivery and aseptic delivery meant hospital delivery. And to conclude on gendered learning, when opening his archives for Frauenkunde, Max Hirsch wrote to several women and including those very active in the women's movement in Germany. And the most impressive answer came from a Saxonian woman, from Marie Stritt, who answered on his question to deliver an article for the first volume of the Archives of Women's Study. To my regret, I cannot respond to this request, since I intend to devote my time and energy to the collaboration on an archive of the study of men, which in my opinion meets an even more urgent event. Thank you.
Thank you, Fritz. And thank you, everyone. As a medievalist, hospitals for women giving birth exist. In Siena, there's quite a famous one called Ospedale Molagnese, which is founded by a woman. So there's a lot going for it. But women went to hospitals because they had no family ties. And if you had no family ties, it probably meant your child was illegitimate, which is something that Fritz brought up when he talked about the maternity hospital in the late 18th century. But though the man didn't seem to, the founder didn't seem to care one way or the other. But so it's interesting to see how these ideas are shifting and how hospitals become a place of, I think Kathleen mentioned this is kind of like mechanized birth, like like you're put on a little conveyor belt. Whereas before it was just out of necessity because you needed the support and that support wasn't there because you didn't have family ties. Okay, no one needs to hear my voice anymore. Let's hear some questions, please. Oh, thank you. Please, thank you. Zahra, thank you so much. To Fritz, thank you for opening up many ideas for me to think about. I wonder if there is a relationship with the biographies and our personal lives of these men with their writings and ideas.
Well, of course, there's always a relation, but it's not easy to be sure which one precisely, because all the men came from very different social spaces. They came from from very different political ideas. Max Hirsch, the very founder of this project, today is celebrated as the founder of social gynecology, which in today's remembrance within the gynecologic community is completely dissolved from racial hygiene, which is not really correct. And of course, Max Hirsch had to leave Germany, and he had left late. He had to leave Germany because of the racist Nazi regime and being called a non-Aryan, even if he did not went to the synagogue or so. So we have kind of a leftist part of racial hygiene together with a very right-wing part of racial hygiene. We have a group of men aiming at understanding women in all what they can imagine. We have academics, professors, and we have obstetricians and gynecologists outside academia. So it's not that easy. Of course, people who studied medicine in early 20th century and late 19th century came from a relatively small social group still. But I think that's all what I can say to bringing together the very different biographies and personalities.
Thanks, Fritz. All right, well, I'm going to use my overarching powers of chairness to ask, oh, cool. I don't know if I can be usurped. So Kathleen, Joanna asked, Langen Hospital's spatial design, did it influence other maternity hospitals?
So thanks, that's a great question. I don't have sort of concrete evidence, that I've seen with other maternity hospitals explicitly saying this is the case, but I suspect it's the case for several reasons. One, it's a very early example of a dedicated maternity hospital being built that at a moment when women are actually starting to birth in a hospital by choice, pay patients, for example. So it is this sort of really early example, and they also publish their reports everywhere. Their plans are actually in every annual report and also included in some of their, they have an associated journal that is published, not as regularly, but sometimes. And the plans are also included there, as well as discussions about their choices about the plans. And that they also brag about, and this sort of segues into a question I had for Fritz, so we could also come back to this, but they talk about in their annual reports who the subscribers were. And the subscribers, on the one hand, were largely, the patrons, the wealthy benefactors, but they also included medical institutions, medical schools, libraries. So there's a decent chance that these plans actually would have been seen because they were so explicitly printed again and again and again over, a decade. So my sense is yes, but I don't have sort of a source to point to on that.
Thank you. Fritz, do you want to hop in on that?
Oh, I can actually ask the question a little bit. I don't know if I said it well, but yeah, so Fritz, something I was wondering as you were giving your paper was the circulation of this journal, right? Who was reading it, and did it have an international readership? Was it really just within Germany? I'm always curious about who's sort of accessing these points of knowledge. So I'd love to hear more if you know about the circulation.
I'm not really sure now, because, well, I just started going through the journal itself. It's quoted quite often in German gynecologic papers, and it opens the world and the eyes of the obstetricians and gynecologists for the point that they might play a major role in the eugenicist debate, which they had not. And then in 1933, they claimed to be the very first who named it, but they had not been these. So this was the eye-opener for them. It's quoted, but I cannot say very much on the readership generally. But the authorship is quite wide. There are several women from the bourgeois women's movement, liberal movement, liberation movement, but these are only 2 or 3, but they are giving quite regularly their papers. And so it's more than 90% men, of course, but I can only say that I found it quoted in the gynecological literature, but I have no idea who else read that journal.
Thanks, Fritz. Kathleen, so I had a question. Obviously, one of the things that we talked about when we proposed this conference, but also a thread that's kind of run through in different forms, is sponsorship. And obviously the thing that stands out is that JP Morgan, well, as JP Morgan, but also that he gave $1 million to build this hospital. And clearly it was highly publicized that he gave $1 million because, it sounds good. It's a good round number. In this period, it is an incredible amount of money. So what are people's I'm not sure if this is something that you've had a chance to look into, but what are people's perceptions of his donation? How are they contextualizing it? Are they seeing it as like altruism? Are people a little more cynical in this era? How are people kind of discussing his donation and later the hospital as part of his legacy? Because obviously, when we think of JP Morgan, we don't necessarily think of his altruism. We think of a lot of other things. So if you'd like to speak to that.
Yeah, it's a good question. And, in its sort of expanded form, the research that this comes from is a sort of microhistory of these very different groups, the women that are using the hospital, but then it does sort of through JP Morgan filter into this whole network of wealthy financiers in the turn of the century. So JP Morgan actually gave to several different medical institutions. That was part of his broader charitable work. And so New York Hospital, for example, which leads into actually really nicely some of the talks from the session just before. So it was not unique in a sort of gift towards healthcare. It also allowed him to sort of So he has personal connections to several of the people involved. So he's actually, his personal physician is James Marco, one of the head physicians of the society. So they have that tie. So it's likely thought that James Marco sort of brokered this as a, oh, well, you give to other hospitals, will you sort of give to our hospital? We need a new hospital building, that sort of thing. And then the architect is related to him in a certain capacity by marriage. So Robertson designs vacation homes for the Morgans, for his children. So it's sort of this network of his influence. And actually another piece of this that I'm really interested in is the way Renaissance revival actually coalesces with Morgan's interests, because of course he's also collecting a great deal of Renaissance art at this time, bring it into New York, right? And so there's this sort of co-terminal, construction of these progressive era charities in Renaissance revival, many of them funded by J.P. Morgan. He's also bringing Renaissance art to New York. And we see the canonization of the Renaissance in art history. So that's also interesting to me as sort of Morgan's involvement. But then as far as how people felt about it, it was sort of a mixed bag. There were people who were excited about it, who did feel it was benevolent, but there was a lot of anxiety about racist anxiety about the encouragement of migrant women to sort of stay in these neighborhoods and have safe deliveries and that sort of thing. So that was one side of it. There were also still very much, even though this was a moment when women were beginning to pay to use maternity hospitals and choose to use them, the hospital was still sort of stigmatized as a space for charity. So there were concerns that you were locating a charity in this neighborhood, right? What would that do? Again, very much framed in racist thinking about who should be in neighborhoods and what it means for different groups of people to be in neighborhoods. And I suppose it's worth mentioning very briefly that here, when I'm talking about racist ideas about communities, it's sort of to varying degrees. We see immigrants from Southern and Eastern Europe, for example, racialized to varying degrees. Black women were racialized. So there are these different levels of racialization, but all of these women, in general, migrant women, are being sort of targeted as undesirable. So there's that side of the coin too, where people are not thrilled to have a space, serving this population. And then the sort of third side of the coin, if you'll allow three, is that the migrant women themselves were not thrilled about it. Many of them did not actually want to use the hospital. And we see the society very intent on literally cataloging. They have every annual report statistics about, the percentage of German women they were able to reach, the percentage of Russian women, right? So very, very much homing in on ethnicity and nativity. Were they immigrants or were they born here? And so many of these women and their husbands, we also sort of hear their voices in some of the published, case studies, were hesitant and brought sort of against their desires. They originally hired a midwife from their home country, but when the physicians found out that there was this emergency, they ambulance transported them, right? And they didn't necessarily want to go. So those were sort of all different attitudes that were present. Sorry, that was a bit long, but I hope that answers your question.
No. That was perfect. Thank you. You touched on a lot more, but it kind of speaks to how donation is not just about the people or the class that the action is supposed to be reflecting into. Because, maybe I take a more cynical view when it comes to, medieval foundations, but I tend to look at it in the context of social capital and the people that they're really trying to kind of, gain that capital and show it to are the people of the same class and status as them. And then they're like, oh, cool, it benefits these other people. But again, I think it's because I'm very cynical, and I know that there are several people listening to me saying this who probably do not agree with me. But I think that's fine. I think there's a religious dimension, but those two don't have to be mutually exclusive, and I don't think they are. So I really appreciate that you broke it apart to talk about the different groups. Fritz has a question for you. So is there any connection between planning the New York lying in hospital and the debate on population in the US?
Yeah, and so I started to touch on this a little bit, but it definitely feeds right into the conversation that you opened up, Fritz. There's very much a eugenicist concern about birthing rates among white women versus where whiteness was considered Western European and not Southern or Eastern European to varying degrees. And so, yes, concerns about those birth rates versus immigrant women from Eastern and Southern Europe versus immigrant women from the Caribbean, from other locations, right? So we see them thinking about this in the very sort of founding texts, right? When they're writing their first annual report about the new hospital building. And it's part of why they really like the location. And this actually, again, goes back to the earlier session just before. This is sort of right above the Lower East Side neighborhood that we were talking about before, but still very close to that neighborhood. So a lot of migrant families. And that was very intentional and sort of sought after because the physicians very much wanted to reach immigrant women especially. And so much so that they actually, so every annual report, they included their own statistics about the ethnicity and nativity and race of the mothers that gave birth within the hospital. And then right next to it, they posted the steerage reports from New York City's statistics of immigration. So you could gauge, like, they want basically say, we match these percentages or we don't match these percentages in these years, and here's our concern about it. And, again, I mentioned briefly earlier, there are these published case studies, and we very much see eugenicist language about who should be birthing, how easy or painful it is for different races or ethnicities of women to give birth, those sorts of things filtering into these discussions within the case studies. So sort of eugenicist ideas about nativity and fecundity are at the heart of the interventions that they want to make, certainly. And that's why it wasn't sort of, it was condensed a bit, but that was part of why I was attending really closely to prophylaxis there, which again, as Anna was saying, it's often framed as benevolent, right? But of course, there's this undercurrent of surveillance and intervention that's always present. So very much so.
Thank you, Kathleen. So I'm going to ask, I'm so sorry, Elizabeth, a question, but she's going to respond in the chat because she has been an absolute trooper and is not feeling well, so she's going to answer in the chat for us. I was curious that, so we see you demonstrated that there was this kind of peak, I believe it was in the 1950s or 60s, now I cannot remember, when there's over 800 maternity wards, and then then they start decreasing. Is there kind of any pushback in the 70s when you kind of see them disappearing almost altogether? Well, I mean, they don't disappear altogether. You said there was one in 2005, but is there any pushback for women to kind of preserve this space as a way of pushing back against the kind of impersonal and extreme medical intervention, because it's kind of in between home birth and in between being in a hospital, I imagine. I don't know if that made sense, the question. Like I said, this is not my field. I luckily has started reading, is it called Medical Bondage? So I have a very, very, very introductory knowledge of 18th, 19th, and 20th century obstetrics. So just give her a moment to respond, so we can continue until she feels the need to respond. I had a question for Fritz. So Kathleen asked about subscription, but I am curious. I know this is probably a terrible question to ask you, since you did mention you just began, but how much of the ideas that are being circulated in this journal are being, integrated or used in maternity wards, if you can trace those ideas at all?
Well, it's hard to say what effectively was talked about in maternity wards 100 years ago. But I think that the main effect is that the bigger part of the audience and of the readers of this journal had been professional obstetricians and gynecologists. So they were influenced by this, and I think that they mostly believed in some kind of racial hygiene. But they tried to, the more active ones tried to come to more maternity clinics, even outside the big cities, because under the condition of anesthesia and maybe increasing the Caesarean section and so on, was claimed the most safe version of birth giving, which would save thousands of lives of mothers and 10 to 100,000 of lives of babies. These are the numbers circulated. So this obviously is just professional policy and nothing more. On the other hand, they tried to get into communal councils, counseling couples if they should marry or not, which obviously was not the very first profession of gynecologists. So the law on this only came in 1935, and the complete so-called left-wing social hygienist already left Germany or had been imprisoned. So one could interpret this as professional politics. But what I want to show is that there's no real break between social hygiene and racial hygiene in the 1920s. And we have to be aware that there's not only the good tradition of social hygiene and then coming over in public health, and then there's the bad tradition which stopped in 1945 of racial hygiene. This is not the story to tell, but the story to tell is that we have medical science of obstetrics and gynecology, which in Germany is nearly the same concerning the academic careers. It's one clinic and it's one director and professor there. Coming out of the hospital and already 50 years later, claiming to explain the world as far as it's the female word. Yes, this is what they are doing. And then detected the role of motherhood in several different discourses of their time, and trying to get the pole position in this discourse, which did not happen. But they tried to.
Of course they did.
Heavy.
Oh, goodness. I guess this statement is born out of ignorance, but I'm surprised that they would be so keen to push cesarean sections, particularly in the early 20th century. I mean, I feel like that's I mean, I know that, you know, compared to even like 50 years before, they've made leaps and bounds in terms of, you know, a lot when it comes to surgery, but I don't know, considering how invasive it is. I find that really surprising. But again, this is coming from a place of complete ignorance about, you know, early 20th century obstetrics and gynecology. So was it kind of, did they have good reason to, I mean, you said they were doing it because they were like ill-preserve the life of the mother and the life of the child, but is it, I don't know, it strikes me as arrogant since even now sections
they just had relative good numbers because usually women did not die in lying in hospitals, and they could count this. And then they and the babies too did not die until they relieved them from the clinic. So they had fantastic numbers, and they were keen on just getting these numbers, and then they were publishing them and claiming that by having all birth under supervision of course, male obstetricians, and in any case of doubt, having a cesarean section would save thousands of lives. This is what they claim, and the numbers are theirs. They're good. But obviously the numbers are not all of this, and we don't have numbers like this for homeborn babies delivered by the mothers together with midwives. And in the 1920s, there is no pressure group to get all the numbers and to publish them and to get into the discourse. As far as I've seen, I don't know, Kathleen, do you have other numbers?
So mine would be, I'm thinking of things that are US specific. So in the context of US healthcare, a lot of people listening might be familiar with the Flexner report, which came out in the early 20th century. And it was a kind of state of the field evaluation generally in medicine, like how are we doing? I'm simplifying it a lot, but you know, and there was a maternity one that was done in the model of this report. And that was done by a Johns Hopkins physician. And it basically showed that the rates of death, maternal mortality and infant mortality were the same, whether you were a midwife delivered or physician delivered. That was like 1911. So, but that was in the US. And there were also then later studies in the 30s that demonstrated not necessarily for all contexts, but septicemia, which was sometimes known as puerperal fever or infection, basically. Those rates also remained equivalent for physicians and midwives through the 30s. So in the US context, at least, there are these published statistics, because also, just as you're saying, Fritz, the hospital also published its own statistics, and they use lots of bold and underlining to say, like, we are doing it better, but then this state of the field, consideration was actually demonstrating, well, so I mean, I don't know if a state of the field example exists like that in the case of Germany. But to your question, Anna, it was my sense is, and the sort of scholarship generally is suggesting it was this posturing and efficiency too.
It just, yes, I don't know. That struck me as odd, but again, not my field.
Well, if you're going to have dedicated spaces, right? If you're going to have dedicated surgical amphitheaters, you have to demonstrate the use of those amphitheaters. So it's also this connection and tethering to space too, right? If you're going to allocate and spend money on. And the surgical amphitheater was a whole, 2 stories, usually a big, thing to include within these facilities.
And if you don't have access to those facilities and you have to result a cesarean section, it's because the mother is dead or dying, and you're just doing it to save the baby. I mean, we have cesarean sections attested to for, thousands of years, but it's not because the mom's going to survive. It's, in many cases, it's so you have an heir, if that's what we're going for in that period. Sorry, Elżbieta has an addition. In Poland, midwives also confirmed that there were no deaths and no cesarean sections, but they sent the high-risk cases to municipal clinics. So again, we might have a question of internal reporting. And to be self-involved, she did answer my question about if there was pushback, and she said, basically, women wanted to keep the maternities, and also the midwives, obviously. They were integrated into the clinics, and they lost direct contact with the women and their profession and independence, and their work was fragmented. So you see a complete destruction of this and kind of in between for women. Thank you very much for that response. And if you make it very fast, Magnus has a question for Kathleen. Since you mentioned the lecture report, did as many institutions close after that second report as did after the lecture report?
No, and I suspect it's because obstetrics was sort of obstetrics was kind of late to the professionalization game in the United States as far as medical specialties go. And so they were already kind of behind, and really the lying in hospital was a lot earlier than a lot of comparable, hospital buildings, major spaces. And so my sense is because of that sort of delay, no. I mean, I might not be right about the reason, but we don't see as many institutions closing because you're right, the Flexner report had a much sort of larger impact on those things.
Awesome. All right, thank you so much for all your truly fantastic papers. Like Chris said, we started off talking about gendered spaces, ended up talking about gendered spaces, which is a great bookend for this conference. And we definitely ended on a high note. So thank you so much for your papers and your responses. So we are just basically gonna move right into our closing statements, which I promise we will keep very brief because I know that everyone is quite tired, and for some of us it's getting quite late. And it's Friday. So I would like to call on Edith. Edith, if you want to give your closing remarks. Oh, we got to unmute you.
I think you will start, you and John Anderson, isn't it?
Sure. I don't mind starting. Sure, we'll start. So I just want to say this has been an interesting experience. Obviously, this was not the conference we had intended, but all things taken into consideration, it's truly been a wonderful experience, and I'm so glad that we were able to, well, I wouldn't say overcome the pandemic because that's not true, but I think that we were able to kind of find a solution that ensured that we brought together as many people as possible from all over the world. And I think that's truly the goal of this conference. And I feel very honored to have been part of the planning committee, and being part of the INHH advisory board has really been just fantastic for me. It's a really great opportunity. I truly love studying hospitals a lot, and I really enjoy the opportunity to talk to all of you about them and hearing all of your papers and perspectives, and also just getting out of my chronological and geographical bubble, which is a problem for a lot of medieval European historians, which is very true. It's truly been a joy to listen to everyone and to work with Edith and Joanna, who honestly are technological wizards and have made this a really dynamic experience for not just for me, but for everyone. And I cannot thank them enough. And everyone may or may not be excited to know that we will be doing a edited volume from the papers from this conference. So this is not the last time you will hear from me. I don't know how you feel about that, but I will be sending out an email with additional information in the coming weeks. So thank you so much to everyone, to the organizers, to the presenters, to our poster presenters, to our chairs who were so wonderful and really helped spark a lot of conversation. I know that for some of us, this is a bit of an odd environment to kind of have, conversations, but, and I'm not talking about myself, I am a dreadful chair, but thank you. And now I'd like to introduce John Henderson, who I know you guys know, but he's going to give kind of parting words from the INHH. So thank you, everyone. It's been a pleasure. John?
Thank you, Anna, very much indeed. I had thought that I might do a summary of the conference, but everybody is exhausted and I think it's totally inappropriate. So I'd really just like to thank everybody who's been involved. I mean, the papers have been extraordinary, I think. I mean, it's very rare that one goes to a conference this big with papers of such a high standard, and it really is the most international conference that we have ever run. And maybe that's the positive side of COVID, one of the very few. So I have enjoyed it enormously. I've learned an enormous amount from people talking about a very wide range of subjects, truly international, on very, very many different perspectives about hospitals. I would like to thank everybody who's been involved. I mean, in Lisbon, Anna and Edith and Joanna, who I think have been remarkable in their efficiency in organisation and their participation and being there the whole time for anybody who felt vaguely panicked if there was something going wrong with the technological side. And to the amazing Anna, who has been extraordinary. She has, as Fritz said, she jumped in to chair sessions, which she did brilliantly. She's too modest. She always thought of lots of questions to ask, and with enormous grace and enormous friendliness. So she has, I think, very much produced the right friendly, relaxed atmosphere in the conference. So to all three of you, thank you enormously. And I'd also obviously like to thank everybody who's given absolutely splendid papers, and the posters as well, which were extraordinarily good, and of course the chairs. So I'm not sure that I'm going to waffle on any longer, because otherwise we'll never get our supper or our breakfast or whatever time of the day it is wherever you are. But I would like to mention that in 2 years' time, we shall be organising another conference. Whether it'll be quite so mega as this one has been, we don't know. We're not quite sure where it will be, but we very much hope to be able to join us. And also the other thing just to mention, as I did at the very, very beginning in my introduction, is that we very much hope that you will keep in touch and that you'll follow us on Facebook and Twitter. And also, as I mentioned at the very beginning, is if you have a short piece that you'd like to write about your research between 500 and 1,000 words, please do send it to Sarah Leonard Brown, whose name and address you will find on the Facebook. So thank you very much to everybody involved and the amazing organisation. Over to you.
Thank you, John. So at the end of these long 3 days of hard work, we want to say something closing remarks. We want to recognize and thank to all the chairs and speakers that during these days contributed to the success of this conference. Thank you very much. Your presentations and posters shared outstanding and outbreaking research and has brought new and important contributions for the study of the history of hospitals, care, and healthcare. For us, these were 3 fantastic days that motivated important debates and the sharing of knowledge. It is important, as Anna said, that we be able to publish all these important works as soon as possible, and we will working together in the first institutional context for this proposed, and we hope to be lucky to have the issue, the edit volume over the next year. Edith and I particularly want to thanks to the International Network for the History of Hospitals, to all the board members for the opportunity to organize this conference, and also thanks to Anna Peterson, with whom we work over the last few months. Without her dedication and support, we couldn't make this Congress possible. Now I will pass to Edith to conclude.
It's okay?
It's okay.
Now, for finish, from Lisbon organization, we want to thank you, Carolina Grillo, the graphic designer, creator of the image of this conference and the dissemination materials. Also to Bernardo Franco, responsible for the capturing and editing images in the opening video with welcome words. Henrique Duarte for the teaser and for his hard work as webmaster during these 3 long days in this complex conference, broadcasting at some time on Zoom platform and YouTube channel. And finally, to our research centers for all the institutional support and financial investment. CHAM, Center for the Humanities, from School of Social Science and Humanities from Nova University of Lisbon, where we are in streaming. European Institute for Culture Science, Padre Manuel Antunes. ARTIS, Institute of Art History, School of Arts and Humanities from University and Lisbon, and Municipality of Lisbon that invites you to visit us as soon as possible. And so, with the feeling of a fulfilled duty, but already with some nostalgia and a great desire to continue our research and diffusion work in the history of hospitals, we say goodbye to all, keep safe, and we hope to see you soon. Goodbye.
Goodbye.